Imagine the scene. An elderly person begins to experience frequent forgetfulness, seems confused in simple day-to-day situations, feels constantly tired, and at times reports tingling in the hands and feet. The family, frightened, immediately thinks of something serious such as the onset of dementia. The doctor is consulted, expensive tests are carried out, and in many cases the initial diagnosis points to Alzheimer's or another degenerative disease. But there is one possibility that is often overlooked: vitamin B12 deficiency. This seemingly small detail can completely change the life of the person affected, because unlike progressive neurodegenerative diseases, B12 deficiency has treatment and can be reversed with proper medical follow-up. The main issue is that the symptoms overlap too much. Weak memory, slow reasoning, difficulty concentrating, mood changes, dizziness, and even balance problems while walking are signs that appear both in cases of dementia and in vitamin deficiency. That is why so many specialists insist that before labeling an elderly person as having an irreversible condition, it is essential to investigate whether there is a B12 deficit. This simple precaution can prevent misdiagnoses, unnecessary treatments, and most importantly, years of suffering for entire families. In recent years, large clinical studies have reinforced this warning. Research shows that low levels of B12 are associated with poorer performance on memory and reasoning tests, and that replacement, when done early, can bring significant results. In other words, what seemed like the onset of dementia may, in some cases, be nothing more than a sign that the body is crying out for more of this essential vitamin. This shift in perspective opens the door to hope. It is not just a minor lab result, but a key to preserving independence and quality of life. The importance of this subject grows even more when we understand its impact on public health. Thousands of elderly people every year are hospitalized, medicated, or even institutionalized due to symptoms that could be reversed with something simple yet neglected: a blood test to measure B12 and the proper supplementation. This neglect does not come from malice but from lack of information and the belief that forgetfulness and fatigue are a natural part of aging. What we are going to explore here is precisely the opposite: the possibility of regaining vitality, mental clarity, and energy simply by paying closer attention to a forgotten vitamin. Vitamin B12, also known as cobalamin, is an essential micronutrient that plays critical roles in practically all human body systems. Unlike other vitamins, it cannot be produced by the body and must be obtained exclusively through diet or supplementation. Its function is so intricate that when lacking, it does not affect just one organ, but sets off a domino effect that impacts blood, brain, muscles, and even emotional balance. That is why aging specialists call it the strategic vitamin. One of the central roles of vitamin B12 is in the formation of red blood cells. Without it, the bone marrow cannot produce mature blood cells properly, resulting in anemia that causes fatigue, paleness, weakness, and shortness of breath, even with light exertion. This type of anemia, known as megaloblastic anemia, is a classic sign of deficiency, but it is not the only one. B12 also participates in the metabolism of amino acids and fatty acids, influencing the production of energy within cells. In the elderly, when energy always seems low, the problem is often not just aging, but a silent failure in B12-dependent metabolism. Another vital point is its direct connection to the nervous system. Vitamin B12 plays a role in maintaining the myelin sheath, the protective layer that covers the nerves. This structure works like the insulation of an electrical wire. Without it, nerve impulses are not transmitted efficiently, causing slowness, communication failures between brain and body, tingling, numbness, and even balance issues. This exact function explains why B12 deficiency can be mistaken for neurological diseases. Without healthy myelin, the symptoms resemble multiple sclerosis, neuropathies, and even dementia-like conditions. In the brain, vitamin B12 actively participates in the synthesis of neurotransmitters such as serotonin and dopamine, which are linked to mood and well-being. When levels drop, it is not uncommon for signs of depression, irritability, and even delusions to appear. It is as if the body loses part of its ability to maintain the chemical balance that regulates emotions and thoughts. Recent studies reinforce this connection, showing that elderly people with low levels of B12 have an increased risk of developing depressive symptoms and cognitive decline, especially when the deficiency is not corrected in time. Finally, vitamin B12 also performs less visible but equally important functions. It participates in DNA synthesis, ensures the genetic integrity of cells, protects the cardiovascular system by reducing homocysteine levels in the blood, and directly influences the maintenance of muscle mass. In other words, we are talking about a multifunctional vitamin whose impact extends from blood to mind, from heart to muscles, making it a key element in any healthy aging plan. Vitamin B12 deficiency in the elderly is not only the result of an inadequate diet, but of a combination of physiological and clinical factors that make absorption increasingly difficult with age. Unlike other nutrients, B12 depends on a complex absorption process that begins in the stomach, passes through the small intestine, and requires the presence of specific proteins, such as the so-called intrinsic factor. This path, which seems simple in young adults, becomes faulty in many elderly people, and that is why deficiency grows silently after the age of 60. The first obstacle is reduced gastric acidity. For B12 in food to be released and bind to the necessary proteins for absorption, the stomach must produce sufficient hydrochloric acid. With aging, acid production decreases, a condition called hypochlorhydria. This means that even if the elderly person consumes meat, eggs, or dairy products, the vitamin may not be properly released. The result is poor absorption and progressively lower serum levels, even in people who believe they have a good diet. Another very relevant factor is the chronic use of medications. Elderly people generally use more drugs daily than any other age group, a phenomenon called polypharmacy. Among the most common are proton pump inhibitors, such as omeprazole, used for gastritis and reflux, which reduce stomach acidity and consequently B12 absorption. In addition, metformin, widely prescribed for type 2 diabetes, directly interferes with intestinal absorption of this vitamin. The continuous use of these drugs for years creates the perfect ground for deficiency to develop unnoticed, until neurological or hematological symptoms become evident. It is also important to highlight the impact of diet. Many elderly people reduce their intake of meat and dairy products due to chewing difficulties, medical restrictions, or food preferences. This reduction lowers the natural supply of vitamin B12, which is found almost exclusively in animal-based foods. Vegetarians and vegans in this context are even more vulnerable if they do not use supplements or fortified foods. Furthermore, situations of social or economic vulnerability may limit access to a rich and varied diet, increasing the risk of nutritional deficiencies. Adding to all this, there are specific clinical conditions that become more common in old age, such as atrophic gastritis, celiac disease, intestinal changes after surgeries, and even pernicious anemia, which compromises the production of intrinsic factor essential for vitamin absorption. Each of these conditions adds a layer of risk, making it practically inevitable that part of the elderly population will develop low levels of B12 over the years. The conclusion is clear. Deficiency of this vitamin is not a problem limited to rare cases, but a common reality in old age. Many times the symptoms are attributed to normal aging, which delays investigation. That is why more and more specialists advocate that B12 testing be considered part of the routine checkup for the elderly, especially those who present neurological signs or make chronic use of drugs known to reduce absorption. Vitamin B12 deficiency is one of the most insidious conditions in geriatric medicine because its symptoms disguise themselves as common signs of aging or even as serious conditions such as dementia and depression. The elderly person who begins to forget appointments, lose objects around the house, or feel slower when reasoning may immediately be interpreted as someone undergoing cognitive deterioration. But in reality, what may be behind these signs is the silent deficit of a single vitamin. This similarity confuses family members, caregivers, and even health professionals, delaying diagnosis and prolonging suffering. One of the most emblematic symptoms is the loss of short-term memory. The elderly person who does not remember what they had for breakfast, who repeats questions already answered, or who forgets conversations from just a few hours earlier, may be mistaken for someone in the early stages of Alzheimer's. However, This memory failure, when related to B12, is usually accompanied by other alterations: unexplained fatigue, difficulty concentrating, and a constant feeling of discouragement. It is precisely this combination that distinguishes vitamin deficiency from classic dementia, but it requires a careful eye to be perceived. Another group of symptoms that generates confusion is peripheral neurological. B12 deficiency damages the myelin sheath that covers the nerves, causing signs such as tingling in the hands and feet, numbness in extremities, and even difficulty maintaining balance while walking. Many elderly people report frequent stumbles, unexplained falls, or the sensation that their legs don't respond. These symptoms may be erroneously attributed to aging, muscle weakness, or even degenerative diseases, but in reality, they reflect nerve impairment that can be reversed with proper treatment. The emotional impact is also significant. B12 deficiency may manifest as irritability, anxiety, apathy, and even depressive states. Families notice sudden mood changes and often assume they are dealing with a psychiatric disorder or a natural reaction to aging. The key detail is that when the vitamin is replenished, these behavioral changes tend to improve remarkably, revealing that they were not signs of an isolated mental illness, but of a brain lacking essential nutrients. In addition, general physical symptoms such as intense fatigue, muscle weakness, dizziness, and palpitations complete the picture, but are often interpreted as just aging or as consequences of other chronic conditions common in this age group, such as hypertension or diabetes. The danger of this confusion is that without the correct diagnosis, B12 deficiency can progress and cause irreversible neurological damage. This means that identifying the signs early is not only a matter of improving quality of life, but also of preventing permanent sequelae. This overlap of symptoms makes B12 testing indispensable for any elderly person who presents cognitive, neurological, or energy complaints. Ignoring this possibility can lead to years of inadequate treatments, loss of autonomy, and even unnecessary institutionalization. On the other hand, recognizing that the forgotten vitamin may be the culprit opens the way for simple and effective interventions that restore mental clarity, physical vigor, and hope to those who already believed they were in a process with no return. The brain is, without a doubt, one of the organs most affected by vitamin B12 deficiency. This happens because this vitamin is directly involved in fundamental processes for neurological health, such as the production of myelin, the synthesis of neurotransmitters, and the DNA metabolism of nerve cells. When B12 is lacking, these mechanisms fail in sequence, resulting in progressive decline that can be mistaken for neurodegenerative diseases. Modern science has shown, with increasing clarity, that this relationship is much stronger than previously thought. Recent research shows that elderly people with low levels of B12 perform significantly worse on tests of memory, attention, and processing speed compared to people with adequate levels. Longitudinal studies further indicate that prolonged deficiency is associated with a higher rate of brain atrophy visible in MRI scans. In other words, it is not just a transient biochemical alteration. The lack of B12 can literally shrink the brain over time, contributing to cognitive decline. Another important aspect is the relationship between B12 and homocysteine, an amino acid that, when elevated in the blood, is linked to an increased risk of cardiovascular diseases and also to cognitive impairment. Vitamin B12, along with folic acid, helps metabolize homocysteine and keep it at safe levels. When B12 is low, homocysteine rises, increasing inflammation and oxidative stress in the nervous system. This process accelerates neuronal damage and worsens brain function, creating a vicious cycle that favors mental decline. In addition, works published in high-impact scientific journals suggest that B12 supplementation, when administered in elderly individuals with deficiency detected early, can stabilize or even improve cognitive functions. This is not a cure for established dementia, but a window of opportunity to slow down symptoms that are often wrongly attributed to natural aging. This is the point where specialists insist investigating and treating early can make the difference between an elderly person who is dependent and one who is able to maintain autonomy. The connection between B12 and the brain is so evident that some researchers advocate including vitamin measurement as part of the standard screening in suspected dementia cases. This is because it is not rare for people to be diagnosed with Alzheimer's or another irreversible condition, when in reality their memory and reasoning deficits originated from a nutritional deficiency. Although not all cases of cognitive decline are related to B12, failing to consider this hypothesis may condemn patients to erroneous diagnoses and expensive, ineffective treatments, while a simple intervention could have brought relief and recovery. The brain ages naturally, but the rhythm and intensity of this process can be modulated. Vitamin B12 is one of the pieces that regulate this mechanism, and its absence accelerates wear and tear. Based on current evidence, it becomes increasingly clear that taking care of this vitamin's levels is not only a nutritional matter, but a strategy for cognitive preservation, prevention of depressive states, and maintenance of neurological health in old age. Aging naturally brings changes everyone expects. Memory may become a little slower, reasoning requires more time, and the body responds differently to effort. However, there are signs that cross the line of what is normal and must be seen as red flags. Vitamin B12 deficiency often manifests precisely at these critical points, and ignoring them means running the risk of confusing a treatable condition with inevitable decline. Recognizing these signals is the first step towards stopping progression and regaining quality of life. One of the main warnings is memory loss that clearly interferes with daily activities. Forgetting a neighbor's name or where glasses were placed may be common, but not remembering important appointments, getting lost on familiar routes, or struggling to follow a conversation are signs that something beyond aging is occurring. When this forgetfulness is accompanied by irritability, lack of energy, or apathy, the possibility of B12 deficiency must be seriously considered. Another critical point is the presence of peripheral neurological symptoms. Persistent tingling in the hands and feet, sensations of numbness or burning in the extremities, and loss of balance when walking are not natural parts of aging. These signs indicate that the nerves may be compromised by vitamin deficiency, and ignoring them can lead to frequent falls and irreversible neurological damage. The elderly person who frequently stumbles at home or reports the feeling of heavy legs should have B12 levels investigated. The combination of mood changes with cognitive symptoms also deserves attention. Depression, anxiety, or sudden behavioral changes, when they appear without a clear emotional trigger, may be linked to vitamin deficit. Many times these complaints are treated only with antidepressants, without evaluating the nutritional aspect. This leaves the underlying problem unresolved, and symptoms persist, perpetuating unnecessary suffering. Another warning sign is extreme fatigue that does not improve with rest. Elderly individuals who report constant tiredness, shortness of breath with minor efforts, or weakness may be suffering from megaloblastic anemia caused by B12 deficiency. Pale skin and frequent dizziness complete this picture and indicate that further investigation is necessary. Finally, there is the silent risk group. Elderly individuals who use chronic medications such as omeprazole or metformin, as well as vegetarians, vegans, and those who have undergone gastrointestinal surgeries. In these cases, even before evident symptoms appear, medical follow-up with B12 testing should be routine because the risk is much higher. In summary, signs of progressive forgetfulness, tingling, imbalance, extreme fatigue, and emotional changes should not be considered normal aging without investigation. They are in fact the body's way of asking for help, and may be the key to a simple diagnosis and a treatment that completely changes the perspective of aging. Not every elderly person needs to rush and request vitamin B12 tests indiscriminately, but there are groups for whom testing becomes almost mandatory. These groups include people who, due to health conditions, medication use, or lifestyle, present a much higher risk of deficiency. Identifying them is essential to prevent silent deficiency from settling in and causing neurological and hematological damage. Preventive medicine, in this case, can change the course of an entire aging process. The first group is composed of individuals over 60 years old, even those who appear healthy. This is because the natural process of aging reduces stomach acidity, and with it, the ability to release and absorb vitamin B12 from food. This risk increases even more after age 70, making it reasonable to include vitamin testing in routine exams at that stage. Another important group is people with type 2 diabetes, who use metformin. This widely prescribed and considered safe medication interferes with B12 absorption in the intestine. Continuous use over years can significantly reduce serum levels without the patient realizing it. For this reason, medical societies already recommend that long-term metformin users monitor B12 levels regularly. Chronic users of antacids are also at risk. Omeprazole and similar drugs, which reduce stomach acidity, impair the initial stage of vitamin absorption. Many elderly people use these medications daily for years, believing they are protected against gastritis or reflux, without realizing they are creating a dangerous nutritional deficit. This group requires careful monitoring, especially when symptoms such as fatigue and forgetfulness begin to appear. Vegetarians and vegans, although a minority among the elderly, represent a very high-risk group. Vitamin B12 is found almost exclusively in animal-based foods such as meat, eggs, milk, and dairy products. Without proper supplementation, deficiency is practically inevitable. Elderly individuals who follow these dietary patterns need constant nutritional and medical monitoring, with special attention to signs of deficiency. People who have undergone gastrointestinal surgeries, such as stomach reduction, partial bowel removal, or procedures that alter the digestive tract, also fall into the risk list. In these situations, the body may lose the ability to absorb the vitamin regardless of diet. The same applies to people with conditions such as atrophic gastritis and celiac disease, which affect the integrity of the stomach and intestine. For all these groups, the recommendation is clear. Do not wait for symptoms to appear. The blood test for vitamin B12 levels should be requested preventively, especially when the patient already presents some cognitive, neurological, or hematological complaint. The cost of the test is relatively low compared to the devastating impact of a late diagnosis. Investigating early may not only mean more years of life, but years lived with independence and lucidity. The blood test for vitamin B12 is the most commonly used initial tool to investigate deficiency of this vitamin. It is relatively simple, performed through a standard laboratory blood draw, and provides a measure of the circulating concentration of cobalamin in the body. In theory, it should be sufficient to clarify the diagnosis, but in practice, it presents important limitations that every elderly person and caregiver must understand to avoid a false sense of security when the result appears within the normal range. The reference value varies from laboratory to laboratory, but in general, levels above 300 picograms per milliliter are considered normal, between 200 and 300 a gray zone, and below 200 as deficient. The problem is that this rigid cutoff does not tell the whole story. Many elderly individuals present classic symptoms of deficiency even with levels of 250 or even 350, since the blood concentration does not necessarily reflect the amount of active vitamin in tissues. In other words, it is possible to have an apparently normal test and still suffer from the effects of B12 deficiency. For this reason, experienced doctors evaluate the B12 test together with other markers. One of the most used is methylmalonic acid, MMA, which accumulates in blood and urine when the vitamin is lacking. Another relevant marker is homocysteine, which tends to be elevated when B12 is insufficient. These additional tests help clarify doubtful situations, especially when symptoms are present but B12 levels do not clearly indicate deficiency. Unfortunately, they are not always available in the public health system, which reinforces the need for attentive physicians prepared to interpret the clinical picture beyond the number printed on the report. Another point to consider is that circulating B12 may be influenced by liver disease, kidney problems, and even the use of certain medications. This means that the isolated test can generate both false negatives and false positives. Hence the importance of not looking only at the paper, but at the patient as a whole. When there are complaints of memory issues, tingling, extreme fatigue, and mood changes in an elderly person, deficiency should not be ruled out just because the number was above 200 or 300. In addition, the frequency with which the test should be performed depends on the risk group. For healthy elderly individuals, a measurement every 2 or 3 years may be sufficient. For diabetics on metformin, users of omeprazole, vegetarians, vegans, or people with gastrointestinal diseases, monitoring needs to be annual or even semi-annual depending on symptom evolution. Prevention, in this case, is always cheaper and less painful than dealing with irreversible neurological damage. Therefore, the vitamin B12 test is a central piece in diagnosis, but should not be interpreted in isolation. It functions as a signal that must be confirmed or contrasted with clinical symptoms and, when possible, complementary tests. This approach prevents elderly individuals from being neglected or receiving incorrect diagnoses, ensuring that the investigation is carried out with the depth necessary to preserve health and autonomy. When vitamin B12 deficiency is confirmed, supplementation becomes the main treatment strategy. The great advantage compared to other clinical conditions is that replacement usually brings rapid and significant results as long as it is done correctly. However, there is no one-size-fits-all formula. The form, dose, and duration of supplementation depend on the cause of deficiency, the severity of symptoms, and the individual conditions of each patient. For this reason, the decision should never be based solely on lab results, but always guided by medical evaluation. In mild cases, where the test indicates low levels without major neurological symptoms, it is common to start supplementation orally in tablets or capsules. Doses vary widely, but may reach hundreds or even thousands of micrograms daily, because only a small fraction is absorbed by the body. This method is practical, safe, and effective for elderly individuals who still have preserved intestinal absorption capacity. Monitoring is essential to verify whether B12 levels are truly rising and whether symptoms are improving. When deficiency is more severe, especially in cases with neurological manifestations or pronounced anemia, replacement needs to be done intramuscularly. B12 injections ensure direct absorption, bypassing stomach and intestinal problems that hinder uptake of the vitamin. In these cases, the initial protocol usually involves frequent applications, followed by a maintenance phase that may be monthly or quarterly, depending on clinical response. This type of treatment is considered safe and effective, but requires discipline and ongoing monitoring. An important detail is that supplementation must be adapted to the patient's condition. Elderly individuals with atrophic gastritis, pernicious anemia, or a history of gastrointestinal surgery usually require injections since their bodies cannot properly absorb the vitamin orally. Patients on medications such as metformin or omeprazole may benefit from a combination of oral supplementation with frequent monitoring of blood levels. In all scenarios, medical supervision ensures that replacement is done at the right dose and for the necessary duration, avoiding both persistent deficiency and unnecessary excess. It is essential to emphasize that B12 supplementation is considered safe, even in high doses. As it is a water-soluble vitamin, excess tends to be eliminated in urine, reducing the risk of toxicity. Even so, self-medicating without guidance can delay the diagnosis of associated diseases, such as pernicious anemia, in addition to hindering proper monitoring. Replacement should always be done strategically, accompanied by periodic tests and symptom evaluation. The most important point is to understand that correcting B12 deficiency can transform the life of an elderly person. Improvements in energy, mood, memory, and even walking stability are often observed after just a few weeks of treatment. For many, it feels like regaining years of lost vitality. And precisely because of this, supplementation should not be underestimated. It can mean the difference between a diagnosis of irreversible dementia and the chance to regain autonomy and quality of life. Although supplementation is often necessary, especially in elderly people with absorption difficulties, diet remains the primary natural source of vitamin B12 and plays a key role in preventing deficiency. Unlike other vitamins, B12 is found almost exclusively in animal-based foods, which means that people who reduce or exclude these items from their diet need extra attention. For elderly individuals who already face naturally reduced absorption, maintaining a balanced diet rich in B12 sources can make the difference between adequate levels and a deficiency that compromises brain and body. Meat is the most concentrated and bioavailable source of vitamin B12. Red meat such as liver and beef offal are champions in this nutrient, but more common cuts such as chuck, round, or flank also provide significant amounts. Poultry such as chicken and turkey contribute to a lesser extent but still represent a good option, especially for those seeking leaner alternatives. Fish, on the other hand, is one of the best sources. Salmon, sardines, tuna, and trout offer not only B12 but also omega-3 fatty acids, which reinforce brain and cardiovascular health, creating a double benefit. Eggs, especially the yolk, are also important allies. A single boiled egg already provides a meaningful amount of the vitamin, being practical, accessible, and easy to prepare. Dairy products fall into this same group of daily sources. Milk, cheese, and yogurt are options that, in addition to B12, bring calcium and high-quality proteins, essential nutrients for bone and muscle health in the elderly. For those with lactose intolerance, lactose-free versions are available that preserve the vitamin content. Beyond animal sources, there are fortified foods, which are increasingly common. Some breakfast cereals, plant-based milks, such as soy or oat, and even plant-based meat substitutes are enriched with vitamin B12. For vegetarians and vegans, these fortified foods are an important alternative, although in most cases they still need to be combined with supplementation to ensure adequate levels. The central point is that diet needs to be varied. Relying on only one source of B12 is not enough, because absorption varies from person to person and may be compromised by clinical factors. For this reason, specialists in geriatric nutrition recommend distributing the consumption of these sources throughout the week, ensuring not only intake of the vitamin, but also of other nutrients that work in synergy with it. For many elderly individuals, adjusting diet is also an opportunity to improve their relationship with food. Including fresh fish, boiled eggs, light cheeses, and natural yogurt can be both enjoyable and beneficial, creating a menu that combines flavor and health. More than simply eating for eating's sake, it is about eating to preserve the mind, protect the nerves, and maintain the vital energy that B12 helps sustain. Although diet plays a central role in maintaining adequate vitamin B12 levels, in many elderly individuals, deficiency is not only due to insufficient intake, but also to clinical problems that compromise absorption and metabolism of this vitamin. Understanding these causes is essential to avoid incomplete diagnoses or insufficient treatments, since simply increasing the consumption of B12-rich foods may not solve the problem. One of the most common factors is pernicious anemia, an autoimmune condition in which the body produces antibodies that destroy the stomach cells responsible for producing intrinsic factor, a protein essential for vitamin B12 absorption in the intestine. Without intrinsic factor, even high doses of ingested vitamin are not absorbed properly, and deficiency develops progressively, often going unnoticed in the first years. Symptoms may be subtle, including fatigue, weakness, tingling in the hands and feet, mood changes, and eventually problems with memory and concentration. Other gastrointestinal conditions also influence absorption. Gastric surgeries, such as partial gastrectomy or gastric bypass, can significantly reduce the ability to absorb B12 because they decrease functional stomach volume and, consequently, acid and intrinsic factor production. In addition, conditions such as atrophic gastritis, celiac disease, short bowel syndrome, or chronic infections by Helicobacter pylori can interfere with intestinal absorption, making oral supplementation less effective. Medications commonly used among elderly people also deserve attention. Omeprazole and other proton pump inhibitors used for reflux and gastritis reduce stomach acidity necessary to release B12 from foods. Metformin, widely prescribed for diabetics, can interfere with the absorption of the vitamin in the small intestine. In both cases, even an adequate diet may not be enough to maintain proper levels, making periodic testing essential. Another relevant factor is advanced age. As the years go by, stomach production of hydrochloric acid naturally decreases, a process known as hyperchlorhydria. Without sufficient acidity, B12 bound to food proteins is not released and consequently cannot be absorbed. This phenomenon explains why many elderly individuals present deficiency even while regularly consuming B12-rich foods. It is important to emphasize that some deficiencies may go unnoticed for years, manifesting only when there is already significant neurological or hematological impairment. Symptoms such as memory problems, mental confusion, tingling, balance disturbances, persistent fatigue, and paleness should always raise suspicion of B12 deficiency, regardless of diet. Only careful medical evaluation that considers medical history, medication use, past surgeries, and lab tests can identify the true cause and guide proper treatment. The main message for elderly individuals and caregivers is clear. Low B12 is not always resolved through diet. Recognizing clinical factors and understanding the interaction between medication, diseases, and intestinal absorption is essential to prevent serious complications, including irreversible neurological damage. Continuous professional monitoring transforms early detection into effective intervention, protecting memory, mobility, and quality of life. Detecting vitamin B12 deficiency before damage becomes irreversible depends on paying attention to warning signs that often go unnoticed, especially in elderly individuals for whom these symptoms may be mistakenly attributed to normal aging. Recognizing these manifestations early is crucial because rapid intervention can reverse cognitive, neurological, and hematological alterations, restoring lost functions and preventing severe complications. The first group of signs involves subtle but progressive neurological alterations. Tingling or pins and needles sensations in hands, feet, or legs, loss of tactile sensitivity, balance problems, and unsteady gait are manifestations that reflect peripheral nerve damage. Ignoring these symptoms can lead to frequent falls, fractures, and reduced autonomy, whereas proper B12 replacement often reduces or even eliminates these changes when initiated in time. Another set of signs relates to cognitive function. Forgetfulness, mental confusion, memory lapses, difficulty concentrating, and mood changes are often attributed to age or dementia. Recent studies show that many elderly individuals initially diagnosed with mild cognitive decline actually had B12 deficiency, and that vitamin replacement significantly improved cognitive performance and mental clarity. These findings reinforce the importance of considering B12 as a modifiable factor before concluding irreversible degenerative processes. Hematological symptoms also deserve attention. Megaloblastic anemia is characteristic of B12 deficiency, causing extreme fatigue, paleness, shortness of breath, palpitations, and muscle weakness. In elderly people, these signs are often neglected or confused with other chronic conditions, delaying diagnosis and increasing the risk of cardiovascular complications and hospitalizations. A routine blood count, combined with serum B12 measurement, can quickly clarify the situation, allowing appropriate intervention. In addition to the classic signs, there are less recognized but equally important manifestations. Gastrointestinal alterations such as loss of appetite, diarrhea, or constipation may accompany B12 deficiency. Changes on the tongue, including inflammation, intense redness, or burning sensations, may also indicate insufficient levels of the vitamin. Neuropathic pain and mood alterations, such as irritability or depression, complete the alert picture that, if ignored, significantly compromises the quality of life of the elderly. The key point is that any new neurological, cognitive, or hematological symptom, even if mild, should raise suspicion of B12 deficiency, especially when risk factors such as advanced age, history of atrophic gastritis, chronic medication use, or previous gastrointestinal surgeries are present. Regular consultations, open communication about symptoms, and periodic lab tests are strategies that transform early detection into effective prevention, preventing a treatable deficiency from evolving into permanent damage. The investigation of vitamin B12 deficiency depends on specific laboratory tests that not only confirm the deficiency, but also differentiate its causes and guide the most effective form of treatment. Among the most used exams, the first step is serum vitamin B12 measurement, which evaluates the total amount of the vitamin present in the blood. Values below the reference limit indicate the need for more detailed evaluation, especially when the patient presents neurological or hematological signs compatible with deficiency. However, isolated interpretation of this test is not always definitive, since intermediate levels may mask functional deficiency. For doubtful cases, measurement of a methylmalonic acid, MMA, and homocysteine becomes essential. Methylmalonic acid increases when there is B12 deficiency in tissues, serving as a sensitive marker of functional deficiency even if serum measurement is borderline. Elevated homocysteine indicates compromised B12 metabolism and may contribute to cardiovascular risk, in addition to reinforcing the need for intervention. The joint analysis of these markers provides a more precise overview, allowing the physician to decide whether oral supplementation is sufficient or whether parenteral administration is necessary. In addition, hematological tests such as the complete blood count help identify megaloblastic anemia, typical of prolonged B12 deficiency. This condition is characterized by red blood cells larger than normal, macrocytosis, low hemoglobin, reduced red cell count, and cellular morphology alterations. In elderly people, this anemia may coexist with iron or folate deficiencies, requiring careful interpretation to avoid misdiagnosis and ensure targeted treatment. In specific situations, it may be recommended to investigate the presence of anti-intrinsic factor antibodies or anti-parietal cell antibodies, especially when pernicious anemia or autoimmune causes of B12 deficiency are suspected. Detecting these antibodies not only confirms the diagnosis, but also indicates the need for continuous supplementation and long-term monitoring, since oral absorption may be insufficient. Another relevant point is the frequency of testing. In asymptomatic elderly individuals, especially those with risk factors such as prolonged proton pump inhibitor use, gastric surgery, or restrictive diet, periodic evaluation every 12 months or according to medical guidance is recommended. For symptomatic patients, monitoring should be stricter, adjusting supplementation doses according to treatment response and lab levels. The central objective of all investigation is to provide a solid basis for clinical decision-making. Correctly understanding the results allows the physician to choose the appropriate replacement route, oral, sublingual, or injectable, and determine treatment duration. In this way, vitamin B12 deficiency ceases to be a vague suspicion and becomes a manageable condition, preventing irreversible neurological damage, improving cognition, energy, and quality of life for the elderly. Vitamin B12 supplementation is the decisive step to restore adequate levels, relieve symptoms, and prevent neurological and hematological complications. The choice of form, dose, and frequency depends on individual factors, including the severity of deficiency, presence of clinical symptoms, age, gastrointestinal conditions, surgical history, and use of medications that interfere with absorption. In elderly individuals, this decision must always be guided by a physician who can adjust therapy according to response and subsequent laboratory tests. The most common forms of replacement include oral, sublingual, and parenteral injections. Oral supplementation is effective in mild or moderate cases, especially when gastrointestinal absorption is not impaired. Typical doses range from 500 to 1,000 micrograms per day, allowing even small amounts absorbed to be sufficient to correct the deficiency. The sublingual form, which dissolves the vitamin directly under the tongue, offers faster absorption and is useful for patients with mild digestive problems while maintaining the practicality of daily use. In cases where gastrointestinal absorption is significantly impaired, such as in pernicious anemia, partial gastrectomy, or chronic use of certain medications, the parenteral route becomes essential. Intramuscular injections of cyanocobalamin or hydroxocobalamin allow the vitamin to reach the bloodstream directly, bypassing digestive barriers. The initial schedule is usually intensive, with weekly or bi-weekly doses until levels normalize, followed by monthly maintenance to ensure adequate long-term levels. The ideal dose is not only a matter of laboratory numbers, but also of clinical monitoring. Signs of improvement include reduction of tingling, improved balance, increased energy, mental clarity, and recovery of cognitive function. Medical follow-up should include periodic reassessment of serum B12, methylmalonic acid, and homocysteine, especially in the first months of supplementation, to adjust the dose as needed. In addition to direct replacement, it is important to encourage the intake of foods naturally rich in B12, such as lean meats, fish, eggs, and dairy, even when supplementation is necessary. This approach contributes to a broader prevention strategy, strengthens healthy eating habits, and may reduce the need for higher supplementation doses over time. In elderly vegetarians or vegans, the use of fortified foods or oral supplements is particularly relevant, ensuring that diet is not a limiting factor. The key point is that B12 supplementation, when correctly indicated, is safe, effective, and capable of reversing significant clinical deficits. Associated with early detection, medical follow-up and education on warning signs, it becomes a powerful preventive intervention, able to preserve memory, mobility, and quality of life in elderly individuals, even at advanced ages. To consolidate all knowledge about vitamin B12 deficiency and ensure that the elderly person or caregiver is prepared for an effective medical evaluation, creating a complete checklist is essential. This resource works as a practical guide, allowing identification of warning signs, organization of observed symptoms, and formulation of objective questions for the consultation, promoting a prevention and intervention-centered approach. The checklist begins with neurological and sensory symptoms, including tingling or numbness in hands, feet, or legs, difficulty walking, loss of balance, dizziness upon standing, instability, muscle weakness, and changes in fine motor coordination. Each of these signs should be recorded with frequency, intensity, and onset, so that the physician can correlate them with the severity of the deficiency and assess whether additional tests are necessary. Next, it includes cognitive and behavioral symptoms, such as recent memory lapses, difficulty concentrating, mental confusion, mood changes, irritability, mild depression, loss of interest in previously enjoyable activities, and difficulty making simple decisions. Recording these changes helps differentiate B12 deficiency from more complex degenerative processes, offering objective data to support medical investigation. The checklist also highlights hematological and physical symptoms, such as intense fatigue, paleness, shortness of breath, palpitations, loss of appetite, gastrointestinal alterations, and an inflamed or red tongue. These signs, often underestimated, provide crucial clues about the presence of megaloblastic anemia and justify performing a complete blood count and specific measurements of vitamin B12, methylmalonic acid, and homocysteine. In addition to identifying signs, the checklist guides the formulation of strategic questions for the medical consultation, such as, are my B12 levels low for my age? Do I need oral or injectable supplementation? Which tests should I repeat and how often? Is there a connection between my neurological symptoms and B12? How can diet complement the treatment? And which signs indicate urgency for intervention? These objective questions promote effective communication and increase the likelihood of an appropriate therapeutic approach. The final goal of this section is to transform complex information into practical actions. The elderly person or caregiver becomes able to monitor symptoms, record changes, organize clinical information, and ensure that each medical visit is productive. With this, B12 deficiency ceases to be a vague suspicion and becomes a treatable condition, with direct impact on preserving memory, mobility, and quality of life, consolidating the knowledge from previous sections into a concrete and applicable daily resource.